Thank you for inviting me to join the panel. I'm an associate professor of biostatistics at Rutgers School of Public Health in New Jersey. I am here today representing a study on the health impacts of Hurricane Sandy in New Jersey, which was a widespread disaster involving the temporary evacuation of hundreds of thousands of people in a densely populated and highly diverse state. And I just want to piggyback on some of the comments from Carla and Deanne about the diversity of our state. Our state is about 20% foreign-born, including many new arrivals, and they represent a very important vulnerable population in New Jersey, as well as an important population of healthcare providers. So the study was funded by the CDC via a subcontract with the New Jersey Department of Health. So the work was done by faculty and staff at Rutgers, at our School of Public Health and at New Jersey Medical School in collaboration with the state epidemiologist, Assistant Commissioner of Health, Dr. Christina Tan. Now, I'm not just mentioning this just to be respectful of Dr. Tan, although I do have a lot of respect for her and appreciation, but I also want to provide this information because it's background to some of the issues that I'd like to raise today. First, our collaboration deputized Rutgers faculty and staff to carry out Hurricane Sandy research, temporarily extending the research capabilities of the New Jersey Department of Health. This was both a blessing and a curse. The blessing, hopefully, is obvious. We were able to handle large amounts of data and study the health effects of Hurricane Sandy using hospital discharge data, mortality data, surveillance data from the state's Poison Control Center, and survey data, including the CDC-funded New Jersey Behavioral Risk Factor Sample Survey. So the state could not have pursued an extensive project like this without compromising their own ongoing public health responsibilities. Now, the downside. Well, the downside included managing a huge amount of sensitive data that normally resides within the Department of Health's servers. So we had to move a lot of that data over to Rutgers, and especially the emergency data at hospitals, not so much the admissions, which can be handled on a normal desktop computer, but the emergency data is huge and required us to develop a complicated management system involving IT at our institution, who normally manage data like high throughput experiments and genomics and RNA-seq and things like that, where there's not a concern necessarily about privacy and anonymity. So it was a very complicated system for managing the data and making sure that it was truly secure. It also involved a very complex IRB application. So even though these studies involve no direct contact with subjects nor any intervention, we still had to go through the state's IRB and our institution's IRB. Okay, and these are expedited studies, okay? They don't require full review board, but with this many sources of data and two institutions involved, we had a lot of work to do with the IRB. Now, Hurricane Sandy made landfall in 2012. In 2014, ASPR actually proposed a new review mechanism that could have bypassed these difficulties, the Public Health Emergency Research Review Board. However, it looks like the data sets that the Public Health Emergency Review Board, the data sets that they cover, actually don't include state-specific hospital billing data, which was one of our major data sources. And so I would recommend that we look at this Public Health Emergency Research Review Board and consider, what it is they can do to facilitate the involvement of academic centers to expand the capacity of departments of health. The other thing about the IRB, it takes time, and we couldn't even apply for IRB till we knew we had the funding. And while this doesn't have any impact on the analysis of, say, hospital billing data, but when you're looking at, for example, the behavioral risk factor sample survey, okay, so this is conducted annually in all the states, and there's a particular study design, and there are particular questions. But we wanted to add questions, and we also wanted to look at the study design and see whether it was going to actually capture some of the areas that were most impacted by Sandy, such as the coasts of New Jersey. And so we were not, because of we had to wait for funding and we had to wait for the IRB, we actually could not pose questions through the BRIFIS, the Behavioral Risk Factor Sample Survey, until 2014. So it was more than a year and a half after Sandy made landfall. So a lot of the questions that we posed were going to be subject to recall bias and ultimately be less reliable. Now, we were all very, very jealous of nearby New York City, which seems to have the capacity to kind of expand out as needs arise. But I think that the budget for the state of New Jersey Department of Health is a little bit more fragile and can't, say, oh, a hurricane hit in October. Well, when we roll out BRIFIS in January, let's add these questions. I mean, we just couldn't do that, but they did. So for a state like New Jersey, and probably this is true for other smaller states, but with big populations that are at risk of disasters, the standing funding streams for disaster research need to be available at all times. They don't have to be used. They can be sitting in a dedicated pot and then when needed, replenished, rather than waiting for the federal government to make a research opportunity available. So going back to talking about New York City, where I actually live. What do I do in New York City? I work in New Jersey. So in New York City, a disaster in New York City is a disaster in New Jersey. So we've seen this multiple times. Notable examples include the World Trade Center in 9/11 and Hurricane Sandy. It would be very helpful if the federal government would provide definitions and standards to be used in future disasters, and this is a point that I think a lot of people have already made today. One source of data or one standardization that we made use of were indicators developed by the Agency for Health Research and Quality called Prevention Quality Indices, which are used to look at hospital admissions for particular diseases or conditions like asthma or heart disease or diabetes that might have been handled by better ambulatory care. So we used those definitions that were already available in order to make sense of whether there were excess morbidity in hospital admissions. So we're not concerning ourselves with saying this is a Sandy, a direct Sandy admission or an indirect Sandy admission. We're just looking at whether there is an excess. And we have to do this very carefully because hospital admissions, there are a lot of secular trends in hospital admissions, the way certain conditions are handled on more of an outpatient basis. And so, looking at just time trends isn't necessarily going to tell you the story. So we have to be, we also made use of data on the impact of Sandy on the economic infrastructure in New Jersey, which happened to be conducted, which was the output of a study by faculty in another one of Rutgers professional school, the School of Public Administration. So as far as like the Poison Center, we also decided that we were going to look at the Poison Center. And this again is a situation where a lack of a uniform definition created some problems. They had a definition that they were using in real time, and post Sandy, when we had the funding, we went back and did keyword searches in order to look at what were Sandy-related Poison Center calls, and there were differences. And so that's something that we need to talk with the Poison Center about in advance of the next Sandy-like disaster in New Jersey. And finally, I want to point out that I represent the academics who do care about the public's health, but we also need to publish. We can extend the capabilities of the health department, bringing in methodologies from a wide variety of disciplines, but we will not have a long academic life if much of our results appear in reports just to the health department. So not all findings rise to the level of a peer-reviewed journal article, but it's important to us, and we would like to see perhaps a special issue of the MMWR dedicated to reporting on some of the work we do in order to understand the impact of disasters on health rather than just providing reports to the health department. Thank you.